Imagine you're in an intensive care unit, just staring intently at a heart monitor.
Right, and the rhythm on the screen is just completely chaotic.
Exactly. It's jagged, it's unpredictable, and, well, it's highly dangerous. But then a doctor pushes a medication through the patient's CV.
And within moments, that jagged line smooths out.
Yeah, it settles into this beautiful, perfectly spaced wave. Looking at that monitor, you'd think the drug just, saved the patient's life.
You really would. But it's actually one of the most chilling scenarios in modern medicine.
Okay, let's unpack this. What if that same medication, the one making the screen look perfectly normal, was actually triggering a microscopic countdown to a fatal heart attack?
It's a brutal lesson, really, one that the field of cardiology had to learn the hard way. Because when we talk about antiarrhythmics,
This is the pharmacological tools used to control the heart's electrical rhythm.
exactly, we are dealing with a profound paradox here. The elegant, textbook theories of how these drugs are supposed to stabilize the heart, they don't always align with the messy reality of human biology.
Welcome to the deep dive. Today we are exploring the fascinating high-stakes world of antiarrhythmics.
It's a wild topic.
It really is. The sources we're pulling from today cover everything from the beautifully neat theories of cardiac pharmacology to the infamous medical trials that completely shattered those theories.
We'll be looking at the debates, the paradoxes, and the misconceptions that literally cost people their lives.
So to even begin grasping how a chemical can fix a broken heartbeat or inadvertently destroy a healthy one, we have to look past the organ itself.
Right. We have to zoom in on the cellular level because every single heartbeat is the result of a microscopic electrical cycle. We call it the cardiac action potential.
The cardiac action potential. It sounds incredibly technical, but the sources break it down into 5 distinct phases, numbered 0 through 4.
Yeah, it's actually a very logical sequence.
And I want to try framing this with an analogy right out of the gate. Think of the heart's electrical cycle, like a perfectly choreographed stadium wave at a massive sports game.
Oh, I like that. That's a highly effective way to visualize it.
Right, because for the heart to pump blood effectively, that electrical wave has to travel across the muscle tissue in total, unified synchronization.
And just like a crowd in a stadium, the individual heart cells aren't moving anywhere. They are just reacting to the cell right next to them.
By opening and closing tiny channels to let charged particles ions flow in and out.
Exactly. So let's start with phase 0. This is the rapid depolarization. Imagine a sudden, massive inward rush of sodium ions into the cell.
So in our stadium, phase 0 is the moment a whole section of the crowd throws their hands up and stands up. The sodium rush is the spark.
Spot on. Then we hit a very brief phase 1, which is just a slight dip in the electrical charge. But the truly unique part of the cardiac cycle is phase 2.
The plateau.
Yes, the plateau. During phase 2, calcium channels open and calcium rushes into the cell while potassium begins flowing out.
So the inward positive charge of the calcium and the outward charge of the potassium kind of balance each other out.
Precisely. They hold the cell's electrical charge steady for a fraction of a second.
So the crowd is standing, holding their hands in the air for a deliberate beat. And the sources emphasize that this plateau is essential, isn't it?
Oh, absolutely. Without that fraction of a second, the physical heart muscle wouldn't have the time it needs to actually squeeze and pump the blood out to the body.
So phase 0 is the spark, but phase 2 is the squeeze.
I love that, yes. Following the squeeze, we need to reset. That brings us to phase 3, repolarization.
So the channels change again.
Right. The calcium channels snap shut, but the potassium keeps rushing out. This rapid loss of positive charge resets the cell back to its baseline.
In the stadium, the crowd sits back down.
Which leaves phase 4, the resting phase.
The crowd is seated, just waiting for the next wave to come around.
For the vast majority of your heart cells, yes, they just wait. But your heart also has specialized pacemaker cells.
And they don't just sit there, do they?
No, they don't.
Yeah.
During phase 4, these pacemaker cells are intentionally leaky. They slowly leak positive ions inward until they hit a critical electrical threshold.
And once they hit it,
They trigger their own phase 0 sodium rush. They start the stadium wave all over again entirely on their own, usually about 60 to 100 times a minute.
wow. Okay, so now we have the blueprint for a healthy heart. But our deep dive is about what happens when this goes wrong. When we get an arrhythmia.
Right. And based on the notes, there are 2 main ways this electrical symphony gets ruined.
The first is called abnormal automaticity. In the context of our stadium, this is like one single, overly enthusiastic fan standing up and screaming 3 seconds early.
Exactly. They trigger a rogue wave that crashes into the normal wave, throwing off the whole section.
And biologically, what is that enthusiastic fan?
It's a normal muscle cell suddenly acting like a leaky pacemaker. It gets irritated maybe by a lack of oxygen or an adrenaline surge, and it fires off a spark when it's supposed to be resting in phase 4.
An ectopic beat.
Right. The second major mechanism is called re-entry.
Re-entry is fascinating to me. This is when the stadium wave doesn't die out after making a lap. It hits a patch of damaged tissue, detours around it, and gets stuck looping endlessly in one corner of the stands.
It just goes in a frantic circle, firing over and over, an endless, self-sustaining loop of electricity.
That sounds terrifying.
It is. If that loop happens in the upper chambers, the atria, you get conditions like atrial fibrillation. If it happens in the lower chambers, the ventricles, you get ventricular tachycardia.
Which is rapidly fatal because the heart is just quivering instead of pumping.
Exactly. It's an immediate medical emergency.
So the central question becomes, how do we design a chemical that finds and stops only those specific errors without stopping the normal healthy beats?
And that is exactly what a British pharmacologist named Miles Vaughan-Williams was trying to figure out at Oxford in 1970.
Working with cardiologist Grama Singh, right?
Yes. They looked at how different chemical compounds altered the shape and speed of that action potential, and they categorized the drugs based on which phase of the cycle they interrupted.
The Vaughan-Williams classification system. The foundational text for cardiac pharmacology.
That's the one.
I have to pause here, though, because the source material mentions a glaring caveat about this origin story.
Oh, it's a huge caveat.
Vaughan-Williams didn't build this system by studying humans in a hospital. He built it in a laboratory using isolated animal tissues. We're talking about rabbit atria and sheep fibers sitting in a petri dish.
Yeah, he sorted the drugs by their dominant electrical signature in that dish. He didn't sort them by their clinical outcomes in living, breathing human patients.
Wait, they based a fundamental human medical classification on a rabbit's heart in a dish? That seems like an incredibly massive leap of faith.
It was a massive leap. And that exact discrepancy between the petri dish and the human patient is the core conflict of our entire discussion today.
But to understand the conflict, we have to look at the system he built. Vaughan-Williams created 4 classes, 4 neat little boxes.
Let's unpack them using our stadium wave. Class I drugs are the sodium channel blockers. They target phase 0.
So by blocking the inward rush of sodium, they muffle that initial electrical spark.
Exactly. They slow down the speed at which the wave travels across the heart tissue, so if a rogue cell is trying to fire rapidly, muffling the sodium channels can stop that rogue wave from catching on.
The sources split Class I into 3 subgroups, IA, EB, and EG, based on how strongly they bind. And there is a historical detail here about a Class IA drug called quinidine that is just mind-blowing.
Oh, the cinchona bark story.
Yes. Quinidine was originally derived from cinchona bark, which was used to treat malaria. And there is a documented case from 1918 where a doctor successfully used it to convert a patient's atrial fibrillation back to normal.
A full 50 years before Vaughan-Williams would invent the system to explain how it was actually working.
Trial and error at its finest. The cure totally predated the science. But I really want to move to Class I because this is where the pharmacology gets incredibly clever.
You're talking about lidocaine.
Yes. So what does this all mean for a real patient in an emergency? When most people hear lidocaine, they think of the dentist numbing their gums. How does a local anesthetic fix a dangerous heart rhythm?
Well, lidocaine is a masterpiece of pharmacology. It possesses a property called use dependence.
Use dependence.
Right. It doesn't just blindly block every sodium channel it bumps into. It has a very high affinity for sodium channels that are frequently opening or channels that are stuck in an inactivated state.
Okay, think about what this means if you're the doctor. You're looking at a patient who just had a massive heart attack. A section of their heart muscle is starved of oxygen.
It's ischemic, yeah.
Yeah.
And that damaged tissue becomes acidic and electrically leaky. It starts misfiring wildly, creating dangerous rogue sparks.
And because those leaky cells are firing rapidly, their sodium channels are open way more often than healthy cells.
Exactly. So when you push lidocaine into the AFE, the drug acts like a heat-seeking missile. It literally ignores the healthy heart tissue where the channels are mostly resting, and it binds aggressively to the rapidly firing channels in the damaged tissue.
It shuts down the rogue sparks while leaving the healthy beats alone. That's incredible.
It really is. So let's look at the remaining bins. Class 2 are the beta blockers, drugs like metoprolol.
And these don't directly block the ion channels, right?
Yeah, they
Yep.
block the beta receptors that respond to adrenaline. In our stadium analogy, class 2 drugs are the stadium security guards.
Huh. Just walking up and down the aisles.
Right, calming the rowdy fans down, reducing the overall sympathetic drive so no one jumps up to start a rogue wave.
And class 3.
Class 3 are the potassium channel blockers. These target phase 3. By blocking potassium from leaving the cell, they physically stretch out the time it takes for the cell to repolarize and reset.
So if class 3 drugs stretch out the reset time, they are forcing the crowd to stay in their seats longer before they are allowed to stand back up.
You are extending what we call the refractory period.
Got it. So if an endless loop, a re-entrant circuit, is racing around the heart, and it hits a patch of tissue that is stuck in a prolonged reset phase.
The loop hits a dead end and dies out. The rogue loop finds no excitable tissue, and the normal rhythm can finally take over.
Which leaves class 4.
Right, class 4 are the calcium channel blockers. Drugs like verapamil. They primarily target the slow inward calcium currents in the AV node, acting as a speed bump for electrical impulses traveling from the top of the heart to the bottom.
4 classes. 4 neat logical bins. You have an electrical problem, you identify the phase, pull a drug from the corresponding bin, and boom, problem solved.
It sounds perfectly rational on paper.
But biology notoriously hates living inside perfect little boxes.
It really does. When you take these beautifully logical rules out of the isolated rabbit tissue and apply them to the chaotic environment of the human body, the borders between those boxes just blur.
Or they vanish entirely. The sources highlight several drugs that completely break the Vaughan-Williams rules. Take adenosine, for example.
Adenosine is wild. Some textbooks just throw their hands up and call it a Class V rebel because it completely defies the four-bin system.
It's used for SVT, right?
Yeah.
That super fast rhythm where an impulse gets stuck looping inside the AV node.
Yeah, AV nodal reentrant tachycardia. Adenosine works by aggressively hyperpolarizing the cells in that node, transiently blocking all electrical conduction.
It's the cellular equivalent of pulling the plug on a frozen computer. A lightning-fast hard reboot for the heart.
That's exactly what it is. You slam it in, the electrical system completely freezes for a couple of seconds.
Which has to be terrifying to watch on a monitor.
Oh, it is. And then hopefully it reboots in the correct rhythm. But the wildest part is its half-life. Adenosine has a plasma half-life of about 10 seconds.
10 seconds? That's nothing.
It's metabolized by enzymes in the blood so rapidly that if a nurse just injected it normally, the drug would be destroyed before it ever reached the heart muscle.
Wait, really?
Yeah, it requires a rapid 4 bolus. It has to be literally slammed into the vein, followed instantly by a flush of saline to push it into the central circulation before it vanishes.
A 10-second hard reboot? That's an incredible party trick. But if adenosine is the rebel, amiodarone is the drug that takes a sledgehammer to the entire system.
Oh, amiodarone. It is technically grouped as a class 3 potassium channel blocker.
Technically.
Very technically, because in reality, amiodarone possesses the pharmacological effects of all 4 classes simultaneously.
It does everything.
It blocks sodium channels like a class 1. It exerts beta-blocking effects like a class 2. It blocks potassium like a class 3. And it blocks calcium channels like a class 4.
Wait, if you've got a drug that is doing everything everywhere all at once to the heart's electrical system, how is that a good thing? Isn't that chaotic for the body?
Well, the irony is that this multi-target shotgun approach makes amiodarone arguably the most effective drug we have for stopping almost any type of arrhythmia.
But at a cost, right?
A massive cost. That efficacy comes with extreme collateral damage. Amiodarone is highly lipophilic.
Meaning it loves fat tissue. It binds to lipids.
Yes, it acts like a sponge in the human body. It accumulates in fat in the liver, in the lungs. Its elimination half-life is not 10 seconds.
No.
It can stretch to over 100 days.
Just to make sure we're grasping the scale of that, if you've ever had a family member on amiodarone and their doctor stops the prescription, that drug is still physically sitting in their organs, slowly leaking back into their bloodstream 3 months later.
3 months later. And because it accumulates so aggressively, the toxicities are just severe. The chemical structure is roughly 37% iodine by weight.
That sounds like a lot of iodine.
It is. It looks structurally similar to thyroid hormone, so it routinely induces massive thyroid dysfunction.
Wow.
And the accumulation in the lungs can cause pulmonary fibrosis, literal scarring of the lung tissue. It even crystallizes and creates visible microdeposits in the patient's corneas.
So to call it a class 3 potassium blocker is almost laughably inadequate. It's an iodine-heavy, lung-scarring, fat-soluble sledgehammer that just happens to fix your heart rhythm.
Exactly. And the inadequacy of the Vaughan-Williams system became so glaring that in 1991, a task force proposed a new framework called the Sicilian Gambit.
What was their approach?
They argued we should ditch the 4 bins and classify drugs by their exact molecular targets, which specific receptor they hit, the exact speed of their binding kinetics.
Which sounds infinitely more intellectually honest than the rabbit tissue bins.
It was far more scientifically accurate. The problem was it looked like a spreadsheet designed by a supercomputer.
Ah, too complicated.
Vastly too complex for a physician to quickly reference during a cardiac emergency. So, Vaughan-Williams remained the dominant teaching tool despite everyone knowing it was a massive oversimplification.
Here's where it gets really interesting, because relying on that oversimplification, trusting those neat little boxes, led to one of the deadliest assumptions in modern cardiology.
Yes. We really need to talk about the pro-arrhythmia paradox.
This is the dark side of antiarrhythmics. The intuitive assumption, the one almost any patient would make, is that a drug designed to fix a heart rhythm is inherently safe.
Right, you take a blood pressure pill, your blood pressure goes down. You take an antiarrhythmic, your rhythm gets safer.
But the terrifying reality of proarrhythmia is that these drugs can actively cause new, far more lethal arrhythmias.
Let's look at the mechanism. Remember how class 3 drugs work? By blocking potassium, they prolong phase 3 repolarization. They stretch out the refractory period.
And on an EKG monitor, a doctor sees this as a prolonged QT interval, right?
Correct. The time it takes for the heart to reset gets wider and wider on the screen. But if you stretch that reset phase too far, the cellular environment becomes unstable.
How so?
Some heart cells finish resetting early, while neighboring cells are still stuck in repolarization. You create an uneven, scattered electrical gradient across the heart muscle.
Oh, that sounds bad.
If one stray spark, one ectopic beat hits that uneven field, the electrical wave fractures. It spirals into a chaotic, twisting rhythm called torsades de pointe.
So the very mechanism you are using to glue the fans in their seats to stop a minor loop can inadvertently set the stage for a catastrophic electrical hurricane.
Exactly. And this wasn't just a theoretical danger. The hubris of assuming these drugs were uniformly safe collided with reality in 1989.
In a landmark study called the Cardiac Arrhythmia Suppression Trial, or KST. Break the KST trial down for us, because the sources paint this as the moment the entire medical paradigm shifted.
So in the 1980s, doctors observed that patients who survived a heart attack often experienced premature ventricular contractions, or PVCs.
Those are the minor rogue sparks we discussed earlier.
Right, and epidemiological data showed a clear correlation. Patients with a lot of PVCs had a much higher risk of sudden cardiac death.
The logic seems airtight. PVCs equal death. Therefore, if we give the patient a strong class-like drug like flecainide to suppress the sodium channels and stop the PVCs, the patient will live longer.
That was the widely accepted hypothesis. And when they ran the ACO-TWAIT trial, the drugs did exactly what Vaughan-Williams said they would do. They suppressed the rogue sparks.
The monitors look beautiful. The perfect monitors from our hook.
The monitors were perfect, but the trial investigators had to abruptly halt the study.
Why?
Because the patients taking the class-like drugs were dropping dead at a markedly higher rate than the patients taking the sugar pill placebo.
Wait, the medication was actively killing them?
Yes. The drugs were suppressing the minor electrical blips, but the powerful sodium blockade was turning the ischemic heart tissue into a powder keg. It was triggering massive, fatal proarrhythmic events.
Wow.
CALIS-T proved something profound. It proved that a surrogate endpoint, a beautifully smooth line on an EKG monitor, is fundamentally different from a clinical outcome.
Which is keeping the human being attached to that monitor alive. Treating the monitor versus treating the patient. Just because the math works in the rabbit tissue doesn't mean it translates to human survival. And the sources note this wasn't just a one-time fluke. They bring up a second massive failure in 2008 called the Andromeda trial.
Right. The Andromeda trial focused on a drug called dronderone. Pharmaceutical companies engineered it specifically to be a safer, cleaner version of amiodarone.
They tweaked the molecule to remove the iodine, right? Hoping to eliminate the severe thyroid and lung toxicities.
A safer sledgehammer. They removed one type of toxicity, yes. But when they gave dronderone to patients with severe heart failure in the trial, it shockingly increased the mortality rate.
Taking away the side effects didn't inherently make the drug a safe tool for failing hearts.
No, it didn't.
So what does this all mean for the field today? You have these high-stakes, double-edged swords. They can stop a fatal loop, or they can trigger torsades de pointe and kill you. Do doctors still even use these things?
Oh, they absolutely do. Antiarrhythmics remain a critical first-line tool, especially for conditions like atrial fibrillation, which affects millions of people.
So amiodarone is still out there.
You will see amiodarone used daily in hospitals across the world, because despite the toxicities, its efficacy is unmatched in an acute crisis.
But the reliance on chemicals has fundamentally shifted, hasn't it? The sources point to a major pivot toward hardware over pharmacology.
A massive paradigm shift. In 1997, the AVID trial proved that for high-risk patients, people who have already survived a life-threatening ventricular arrhythmia mechanical devices are vastly superior to drugs.
We are talking about implantable cardioverter defibrillators, or ICDs. These are the shock boxes surgically implanted in the chest.
Right. If the rhythm spirals into chaos, the device physically senses it and delivers a massive electrical shock to forcefully reset the entire heart.
Like a mechanical adenosine.
Pretty much. The ICD acts as the ultimate safety net. Today, for these high-risk patients, the antiarrhythmic drug is no longer the primary shield. It has been demoted to an adjunct role.
Meaning the drug is just prescribed to keep the rhythm stable enough so that the ICD doesn't have to painfully shock the patient every single day.
Exactly. The hardware saves the life. The chemical just improves the quality of life.
Before we wrap this up, there's one final connection in the sources that proves this isn't just obscure cardiology trivia. Understanding proarrhythmia is incredibly relevant to anyone taking medicine right now.
It really is. The cellular mechanics we've discussed, specifically the danger of stretching out that phase 3 reset and prolonging the QT interval, it's not exclusive to cardiac drugs.
Right.
Many psychiatric drugs, antibiotics, and antihistamines carry a risk of QT prolongation.
Yeah, the notes bring up the massive controversy in 2020 during the early days of the COVID-19 pandemic. There were widespread proposals to treat the virus using the antimalarial drug hydroxychloroquine combined with the antibiotic azithromycin.
And electrophysiologists worldwide immediately sounded the alarm, and not because of politics, but because of pharmacology.
This is the QT interval.
Exactly. Both of those drugs carry known risks of prolonging the QT interval. If you prescribe them together to millions of sick patients, you are dramatically compounding that uneven electrical gradient we talked about.
You are practically inviting torsades de pointe.
It was a stark reminder that the foundational rules of proarrhythmia apply across the entire spectrum of medicine.
It all connects back. The sodium sparks, the potassium resets, the delicate stadium wave of the human heart. Which leaves me with a lingering thought today.
What's that?
Well, we started this journey with Miles Vaughan-Williams in 1970, looking at rabbit tissue in a petri dish, building a neat 4-bin classification system that became unquestionable medical dogma.
Right.
But we've seen how flawed that translation from animal tissue to human survival truly was. The tidy boxes were an illusion, broken by drugs like amiodarone and dismantled by the tragedy of the KIT trial.
It definitely forces us to confront the limitations of our own scientific models. We assumed understanding the mechanism was the same as understanding the outcome.
Exactly. So it makes you wonder, if something as fundamental as how we treat the human heart was based on a flawed, oversimplified model for decades, what other foundational medical truths are out there right now?
That's a great point.
What other perfectly tidy classifications are we just blindly accepting as fact, waiting for their own Cas9 trial to come along and prove them entirely wrong?
It is a vital, humbling question for anyone in science. A reminder that we must always look past the surrogate endpoints and respect the staggering complexity of human biology.
A reminder to always question the perfectly normal monitor. Thanks for joining us on this deep dive. We'll catch you next time.